Blood Component Replacement by Lieutenant Cadet. Procedures. It is often the anesthesia provider who will be responsible for administering blood products. According to Barash et al., it is estimated that 8.3 million units of blood product will come in contact with anesthesia providers each year. Due to this fact, it is clearly evident that anesthesia providers need to have a solid understanding regarding the principles of blood product administration. Currently, the blood supply, as with any anesthetic procedure, there is risk involved with the administration of blood products. The rate of viral infections associated with blood transfusion in the United States has greatly decreased over the last 20 years. This is mainly impartial testing for HIV and hepatitis C, and overall more in-depth testing of donor blood. The rate of transfusion-related hepatitis C is currently the lowest of all strains of hepatitis. 85% of people infected with hepatitis C will eventually progress to chronic disease, and 20% of those with chronic disease will develop cirrhosis. Anywhere from 1 to 5% of those with chronic disease will develop hepatocellular carcinoma. Hepatitis B has the greatest risk of transfusion-related infection. The fact that at the time of donation, donors may have contracted the virus, but are in the 38-day window when the virus is not detectable on surface antigens. 35% of people exposed to hepatitis B will develop the disease. The majority of those who develop the disease will have spontaneous resolution, but 9% will likely develop cirrhosis and 1% will develop hepatocellular carcinoma. The likelihood of contracting hepatitis A from a blood transfusion is very rare, and currently screening for the virus is only done when there is a history of exposure. Since the 1980s, the rate of HIV transmission due to transfusion has greatly decreased. It was the discovery that greatly changed many blood bank practices and has helped decrease overall transfusion infection rates. In the United States, all donated blood products are screened for HIV-1 and HIV-2 virus. Currently, the rate of transmission is approximately 1 in 1.7 million. The family as HIV and is associated with leukemia and lymphoma. All donors in the United States are currently tested for human T-cell lymphotropic antibodies. As such, the risk of transmission is very rare in the United States. Transfusion-related cytomegalovirus, or CMV, is usually not a serious condition and tends to be self-limiting in healthy patients. Immunocompromised patients may experience severe and even fatal infections if exposed to CMV-positive blood. In order to reduce the risk of transmission, immunocompromised patients should receive reduced blood from CMV-negative donors. It is possible for the West Nile virus to be transmitted through blood transfusion. Fortunately, there is a very short window from the time the virus increases the likelihood of West Nile virus positive patients from donating blood, as well as donor screening in areas where the virus is most prevalent. The majority of those infected with West Nile virus will be asymptomatic or have only mild flu-like symptoms. The transmission of malaria via blood transfusion is common in countries where the disease is an epidemic, but very rare in the United States. This disease associated with protozoa is more common in South and Central America, where the disease is much more common. Non-viral transfusion-related infections have a higher rate of morbidity and mortality than viral infections. According to Barash, bacterial contamination occurs at a much higher frequency than any other infection and is associated with substantial mortality. According to Morgan and McHale, it is the second leading cause of transfusion-associated mortality. Unfortunately, transfusion-related bacterial infections occur more commonly than viral infections. There is an increased incidence of bacterial sepsis with platelets due to the fact that they are stored at closer to room temperature and numerous organisms, including strains of Staphylococcus and Klebsiella, can grow on platelets. The risk of sepsis is further decreased with the use of apheresis platelets because they are obtained from a single donor, reducing the risk of contamination. Only a limited number of bacteria are capable of growing on red blood cells. Of symptoms and a varying severity of symptoms. Some will quickly experience fever, chills, tachycardia, dyspnea, shock, and possibly DIC. The source of contamination of blood products can be as simple as skin flora during collection. In order to prevent contamination, proper skin preparation prior to donation and proper storage of blood products is necessary. All blood banks in the United States now test their non-apheresis platelets for bacteremia, as well as many institutions have instituted testing their apheresis platelet units as well. Immune reactions occur when the recipient has or develops antibodies to the donor's blood product. In very rare instances, the donor cells mount an immune response against the recipient. Immune reactions occur when the recipient has or develops antibodies to the donor's blood product. In rare instances, the donor cells mount an immune response against the recipient. Hemolytic reactions involve the destruction of transfused cells by the recipient. Incompatible units of product may contain a small amount of antibodies. If there is a large transfusion of products containing these antibodies, this can lead to intravascular hemolysis. Acute hemolytic reactions occur 1 in every 38,000 transfusions and are usually due to ABO incompatibility, usually from the mislabeling of blood products. Take place in the intravascular and sometimes in the extravascular spaces. The complexes formed by the antigen antibodies activate factor XII. Factor XII helps produce bradykinin by increases capillary permeability and causes arterial dilation, contributing to hypotension. The release of histamine and serotonin from mast cells causes bronchospasm. Up to 50% of patients will also develop DIC. Acute hemolytic reactions can occur with a transfusion as little as 10 to 15 mL of ABO incompatible blood. 1 in 100,000 acute transfusion reactions are fatal. The signs and symptoms of acute hemolytic reactions in the awake patient might include fever, chills, nausea and vomiting, and diarrhea. In the anesthetized patient, acute hemolytic reactions will present with an increase in temperature, tachycardia, oozing at the surgical site, and hemoglobinuria. If an acute hemolytic reaction is suspected, treatment includes immediate discontinuation of the blood product and notification of the blood bank. The unit should be rechecked. Blood should be drawn from the recipient so the lab can centrifuge the blood, and if a pink tinge is noticed, a hemolytic reaction is almost positive. The rest of the treatment should be supportive in measure. It is important to maintain hemodynamic stability with fluid and pressors as needed. Protection of renal function includes maintaining urine with fluids and diuretics as necessary. Supportive measures will also help to prevent the development of DIC. Hemolytic reactions occur within a short period of transfusion, often within days. Delayed hemolytic reactions are thought to be caused by exposure to non-D antigens that the recipient has previously developed antibodies to through either a previous transfusion or pregnancy. Over time, the antibody levels fall too low to be detected. Antibodies against these foreign antigens are triggered on subsequent mild and require only supportive care. Diagnosis of a delayed transfusion reaction can be confirmed by the Coombs test. Non-hemolytic reactions are most likely due to sensitization to donor white cells. The use of a leukoreduced blood product can help to limit these reactions. Febrile reactions are from white cells or platelet sensitivities. These reactions occur in 1 to 3% of patients who have include an increase in temperature of more than 1 degree Celsius within 1 hour of transfusion, and return to normal within 48 hours. Accompanying these symptoms include chills, headache, respiratory distress, and nausea. These symptoms are sometimes described as those similar to the common cold. Treatment is geared towards supportive measures and treatments of these symptoms. Other non-hemolytic reactions include itching related to sensitivity of plasma and can be treated with antihistamines and after only a few milliliters of blood product. Anaphylactic transfusion reactions typically occur in IgA deficient patients who have IgA antibodies. It is estimated that 1 in 800 people have an IgA deficiency. However, the risk of anaphylactic transfusion reactions is very rare and occurs only 1 in every 150,000 free blood units. Transfusion-related acute lung injury, or TRALI, occurs in 1 in every 5,000 transfusions and is most common. Need to be irradiated prior to the transfusion in the immunocompromised patient. Thrombocytopenia following transfusion is caused by the development of platelet antibodies that cause the destruction of the recipient's platelets within 5 to 10 days. The treatment of post-transfusion purpura includes the administration of IgG and plasmapheresis. According to Morgan and McHale, recent studies suggest that perioperative transfusions may increase the risk of postoperative bacterial infection, cancer recurrence, and mortality, all of which emphasize citrate is used as a preservative in blood products. Citrate binds to calcium and during a massive transfusion will bind to the recipient's own calcium, causing hypocalcemia. Citrate is primarily metabolized in the liver, and patients who suffer from any sort of hepatic deficiency are more likely to develop hypocalcemia. During massive transfusions, especially if the rate of transfusion exceeds 100 milliliters per minute. At this rate, hyperkalemia and intraoperative arrest have been reported.